and welcome to the PG classroom. This is the second module of the PG classroom. And this time we have Dr. Gauri from Prabha Eye Clinic and Dr. Meena Nair from Chaitanya Eye Hospital as the discussants, and Dr. Rosmin from Chaitanya Eye Hospital, who will be presenting the case, and Dr. Marian, who is the course director, and the scientific committee member will be coordinating the program. And we also have Dr. Rajesh OT, who is the member of scientific committee. Unlike in the last time, where one PG will be presenting the case and all the question will be bombarding to her, this time we have few more other PGs in the hot seats. So they also can participate actively in the discussion. So we'll straight away go to the program. Before that, I request Dr. Marian to introduce our discussant, Dr. Gauri from Prabha Eye Clinic. Over to Dr. Marian.
Yeah, good evening all. Today we are very lucky to have two great teachers. Dr. Gauri J. Murthy. She is a glaucoma consultant from Prabha Eye Clinic and Vitala International Institute of Ophthalmology. She is the author and co-author for many of the articles in international journals, and she is the reviewer for American Academy of Ophthalmology journal, IJO, as well as she's a very active member in the Glaucoma Society for us. I welcome Dr. Gauri, and thank you so much for accepting our invitation to the short notice.
Thank you.
I welcome Dr. Meena Nair, Senior Consultant Glaucoma Specialist from Chaitanya Eye Hospital, Trivandrum, to mentor the PG as well as to take part in the discussion. Welcome, Dr. Meena.
Thank you.
So, Jocelyn, I think we can straight ahead go to the discussion. You can share your screen.
Yeah, before that, can all of you please switch on the video? Just take a photo. Okay. Okay, thank you. Okay, Dr. Rosman.
My screen visible, sir?
Yes.
Yes.
Good evening, everyone. My patient is a 66-year-old male who is a retired CRPF officer from Trivandrum who was examined in our OPD on 23rd of February 2024. He presented with complaints of diminution of left eye for the past 1 year. History of present illness. Patient presented to the OPD with complaints of diminution of vision in the left eye for the past 1 year, which he noticed as difficulty in reading at distance and near, which was gradual in onset, painless and progressive in nature, not improving with his spectacles. No history of any headache, nausea or vomiting. No history of any associated redness, eye pain, watering or colored halos or photophobia. No history of any flashes or blotters. No history of exacerbation of symptoms on exercise. He consulted an ophthalmologist 2 weeks back and was detected to have increased eye pressure in both eyes and was started on topical medications twice daily. Past ocular history. Patient is using spectacles for the past 25 years and his last glass change was 6 months back. No history of any frequent change of glasses. Patient gave a history of detecting increased eye pressure in both eyes 2 years back during a routine eye checkup for change of glasses and was advised topical medications in both eyes. Patient was on treatment for about 1 month, but then discontinued the same by his own and did not follow up later. No history of any ocular trauma. No history of any prolonged topical medications or topical steroids. No history of any lasers or injections. No history of any ocular surgeries. Past medical history is a non-hypertensive treatment for the past 5 years on tab atenolol 50 mg twice daily and tapped telmisartan 40 mg once daily. No history of any bronchial asthma or heart disease. No history of any other systemic comorbidities. No history of any steroid medications. His personal history is on mixed diet with normal sleep and appetite, normal bowel and bladder habits, and no addictions with no drug allergy. He has no family history of glaucoma.
Dr. Jocelyn, in the personal history, the smoking and alcohol, it may not be an addiction, but maybe you should mention about whether he's a smoker, because the pseudo exfoliation, one of the risk factors is any oxidative stress. So smoking, alcohol, all these, and these can contribute, though it is not proven. So maybe you can tell about smoking and alcohol history also.
Coming to general examination, patient is moderately built and nourished, conscious oriented. He has no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. He was febrile. Pulse rate was 74 per minute. Blood pressure was 120 over 70 millimeters of mercury in right upper limb in sitting position. All peripheral pulsations were felt equally bilaterally. His respiratory rate was 18 per minute. Systemic examination, cardiovascular system was normal. S1, S2 was heard. No murmurs, no carotid brewing. Respiratory system, air entry was bilaterally equal with normal vesicular breath sounds and no adventitious sounds. GIT per abdomen was soft with non-tender and no organomegaly. His higher mental functions were normal. Sensory and motor system was normal. Cranial nerve examination, olfactory nerve was normal. Second, third, fourth, and sixth cranial nerves will be dealt later. Trigeminal nerve sensation over face normal. Muscles of mastication normal. No jaw deviation. Facial nerve wrinkling of forehead normal with no facial asymmetry. Vestibulocochlear nerve no hearing impairment. Glossopharyngeal vagus nerve no difficulty in swallowing with uvula central. Spinal accessory nerve normal shrugging of shoulders. Hypoglossal nerve tongue movements normal with no fasciculations or wasting. No cerebellar signs, no signs of meningeal irritation. Musculoskeletal system was normal. Coming to ocular examination, was orthotropic in primary gaze, no facial asymmetry, no ptosis, proptosis, nystagmus or strabismus, no head tilt, face turn or chin elevation, seductions, versions, and vergence was normal. Visual acuity, uncorrected distant visual acuity was 624 parts, improving to 6x with pinhole. Left eye was 6.9, improving to 6x with pinhole. Dilated retinoscopy with 0.8% tropicamide and 5% phenylephrine at 2/3 meter working distance gave, plus 3.5 diopter in the vertical and horizontal meridian in right eye, and plus 2.25 diopter in vertical meridian, and plus 1.5 diopter in horizontal meridian in left eye, with an acceptance of plus 2 diopters here, right eye improving to 6.6, and left eye plus 0.75 diopter cylinder at 180 degree improving to 6.6. Near-eye was plus 3 diopter sphere in both eyes, improving to N6. Coming to anterior segment examination of the right eye, lid and retinaxa was normal. Conjunctiva was normal with no congestion. Episclera and sclera was normal. Cornea was normal in size, shape, and luster, which was clear, and no endothelial pigment deposits. Anterior chamber had a normal central depth, and peripheral depth was Vander's grade 4. Iris was normal color and pattern with no pseudo-exfoliative deposit seen, nil transillumination defects. Pupil was normal in size and shape. Direct light reflex was brisk and concentric was sluggish. Lens was short and nuclear sclerosis of grade 1. Intraocular pressure was 60 millimeters of mercury at 10:45 a.m. by Goldman acclamation tournament. Anterior vitreous space was clear. Anterior segment examination of the left eye, lid and retinaxa was normal. Conjunctiva was normal with no congestion. Episclera and sclera was normal with no dilated episcleral vessels. Cornea showed a normal size, shape, and luster. Was clear with no endothelial pigment deposits. Anterior chamber showed normal central depth, and peripheral anterior chamber depth was Vander's grade 4 with no cells of flare. Iris was normal in color. Loss of 360-degree pupillary rough knotted. White flaky deposits were seen at the pupillary margin, suggestive of pseudo-exfoliative material. Nil transillumination defects noted. No posterior synecdoche, atrophic patches, neovascularization of iris or peripheral iridotomy noted. Pupil was normal in size and shape, direct and concentric light reflex sluggish, grade 2 relative afferent pupillary defect noted. Lens showed nuclear sclerosis grade 1. Anterior lens capsule showed a grayish central and peripheral zone of exfoliative material deposit with a middle clear zone. Intraocular pressure was 32 millimeters of mercury at 10:45 a.m. by Goldman applanation tonometry. Pronoscopy. Angles were
You can just show the picture like once so
Yes.
that the PGs, other PGs can actually see it.
Okay.
And you can describe the picture.
This is the anterior segment CP showing target sign with the central and the peripheral zone of grayish white exudative material with a middle intermediate clear zone.
How are the margins?
With radiating margins in the peripheral zone.
Doctor, did you comment about the lens? Is there any phacodonosis? Did you assess the stability of the lens?
No gross phacodonosis or subluxation of lens not treatment.
Okay. How do you elicit phacodonosis? On the slit lamp, when you're examining, how will you elicit phacodonosis? How will you check for it?
The dilated pupil, we
Yeah.
ask the patient to look up or down.
Yeah.
And assess the after movement of lens.
Correct. So any movement of the eye, so the after movement of the lens or the shaking of the lens will be obvious. Okay, and then the anterior chamber depth here in this eye, when you compare it with the other eye, which did not have any pseudo exfoliation, was it different?
No, it was same as the other eye.
Other eye. Why am I asking whether it was different? What does it mean if the AC depth is, lesser on this side?
It may indicate a subluxation of lens.
Yeah, so the lens can be anteriorly, pushed, or because of zonular weakness, it may move a little anterior. So subtle differences in AC depth will also give you a clue that there is zonular weakness. You can go ahead, ma. Thank you.
Okay. Pronoscopy done with the femoral Goldman lens. Showed angles open up to ciliary body band in all quadrants in both eyes. No peripheral anterior synechium noted. Nil neovascularization of iris or neovascularization of angles noted. The AV pigmented line anterior to Schwalbe's line noted in the inferior quadrant in the left side suggestive of symbolism.
Yeah.
Coming to the fundus examination, right eye. Distant direct ophthalmoscopy, clear media. Examination of the posterior pole with the 90-degree lens showed a round disc of 1.6 into 1.6 millimeter diameter with the distinct disc margins. Cup disc ratio was 0.6 with a central deep cup with steep temporal and sloping nasal margin. Neuroretinal rim showed an infratemporal pallor with a superior rim less than inferior rim. 360-degree peripapillary atrophy with a prominent inferior alpha zone noted. No disc hemorrhages. Retinal nerve fiber layer was showing prominent infratemporal and a few supratemporal slit defects. Superior bilating of vessels noted with a doubtful early superior notch. Original vessels were normal with an AV ratio of 2:3. No arteriovenous crossing changes noted. Macula was normal with a normal foveal reflex.
1 second, I don't know whether I am seeing it very clearly here or not, but if you can see the disc here, superotemporally, is that a small disc hemorrhage at the edge of the disc? There, yeah, that one. Yes, ma, yes. That one, yes, what you are showing.
Yes.
Is that a hemorrhage? It's okay if you're not, I mean, it looks very suspicious like a disc hemorrhage.
Yes.
That's why I asked. Go ahead, ma, go ahead, please.
Examination of the peripheral retina with indirect ophthalmoscope showed few well-defined yellowish deposits seen around the supratemporal and infratemporal arcade, suggestive of bruisings. Rest of the peripheral retina was within normal limits.
Yeah, even in this picture, it does look like a small disc hemorrhage there. Isn't it?
Yeah.
Looks.
Coming to fundus examination of the left eye, distal direct ophthalmoscopy showed a clear media. Examination of posterior pole with 90 degrees showed a disc of symmetric disc size 1.6 into 1.6 millimeter diameter, round disc, distinct disc margins, cup disc ratio of 0.8 with the pale neuroretinal rim, prominent superior and infratemporal nose with absent inferior rim, with bionetting of both supratemporal and infratemporal vessels. 360-degree peripapillary atrophy with alpha zone and broad ill-defined infratemporal RNFL wedge defects. No disc hemorrhage is noted. AV ratio was normal 2:3. Macula normal with the foveal reflex present. Examination of the periphery with indirect ophthalmoscopy showed a multiple well-defined yellowish deposits seen around the supratemporal and infratemporal arcade and nasal to the optic disc suggestive of bruising. Infratemporal internal empty membrane folds were also seen. Rest of the peripheral retina examination was within normal limits. Coming to the case summary, a 60-year-old hypertensive gentleman with a history of raised intraocular pressure on single anti-glaucoma medication for the past 2 weeks presented to our OPD with complaints of diminution of vision in the left eye for the past 1 year. On examination, his best corrected visual acuity was 6.6 in 6 in both eyes. Pupil showed a grade 2 RAPD in left eye. Anterior segment examination showed a Van Herrick's of grade 4 with a nucleus sclerosis grade 1 in both eyes and evidence of pseudo-exfoliation in left eye. Intraocular pressure was 60 millimeters of mercury in right eye and 32 millimeters of mercury in left eye. Gonioscopy showed an open angle subciliary body with a sample as a line in left eye. Fundus examination showed cup disc ratio of 0.6 with peripapillary atrophy in right eye and 0.8 with supratemporal and infratemporal notch. 360-degree peripapillary atrophy, infratemporal RNFL loss in left eye, suggestive of glaucomatous optic neuropathy.
Why are you saying only inferotemporal RNFL loss in the left eye, Dr. Josin?
And actually,
because if you look at the left eye, see this portion in the superior portion also, there is a diffuse loss of the retinal nerve fiber layer. When the disc is quite cupped, like in this disc where it is almost 0.8, 0.9, the RNFL defect will be diffused. So here the superior RNFL is also not seen. In fact, what you can see is, can you see here inferotemporal? Here, inferotemporal here. This is the remaining RNFL. So that is the only thing. In that you are seeing slit-like changes if you are seeing. Can you understand what I'm pointing out?
yes, ma'am.
Okay, so the everything else here, inferiorly the RNFL is absent. From here till here, this portion, this inferior temporal, this one is the only RNFL which is present. So superior also the RNFL is not seen at all. So you can say it shows diffuse RNFL loss. So how much based on imaging and other things we can find out later on. But clinically, don't say only inferior RNFL loss because here the damage is much more severe. So you can see remaining RNFL in this red-free photograph beautifully, if you can see this. That area where you're showing right now, that is the remaining RNFL. So everything else, it's actually lost. In the remaining also, you can see slit-like defects. Can you make that out? Yeah.
Because of the papillomacular bundle area having its luster, you are able to see that sharp margin of the wedge-like defect.
Here,
but actually, it's an overall diffuse.
Yeah,
NFL
diffuse loss this side. Only that papillomacular bundle, that too only here inferiorly, this portion, that is preserved as far as this picture goes. That is the impression that it gives. Go ahead, Ma.
So Anatomical diagnosis is left eye pseudo-exfoliative glaucoma with both eye meshes and eye.
You mentioned in your right eye also there were disc findings, there were slit-like RNFL changes. Okay, so here at least you should say that it is a glaucoma suspect, because though pseudo-exfoliation is not there, you did mention that there were slit-like RNFL defects both superiorly and inferiorly, which I can see even on the red-free photograph that you are showing. And this disc is also not a completely normal one. At least we can label it as suspicious. And there is that small suspicious, what we are thinking, whether it is disc hemorrhage or not. So you, in your diagnosis, you can put it as suspicious, glaucoma suspect, open angle glaucoma suspect. And in the left eye, it is a pseudo-exfoliation with open angle glaucoma. So don't say right eye is totally normal unless you have investigated it completely.
Okay.
Okay.
Differential diagnosis of pigmentary glaucoma and primary open angle glaucoma.
Yeah.
Coming to the investigations, pachymetry showed a central corneal thickness of 564 micrometer in right eye and 536 micrometer in left eye. That's a normal central corneal thickness. So, coming to the fields.
Dr. Jasmine, I think one of your colleagues can tell about the fields. They said other postgraduates are also there, no? Can someone else read the right eye fields, please? I see Dr. Dalia. Dr. Meena, is it allowed to ask the other PGs?
I think so, because
yes,
that is what Bastin also said in the beginning.
Yeah, no? Yeah. Can you ask Dr. Meena, because I don't know the...
I think Dr. Sonia, can you please unmute and answer Madam's question of reporting
yes,
this?
Okay, just read this field, report this field.
Okay,
Don't get tempted.
Single field analysis of central 24-2 threshold test of right eye in a male patient, showing the indices, the central fixation target and fixation loss 1/15, and no false positive or no false negative errors. Reliable, showing reliable fields.
Excellent.
And with a stimulus of 3 and the theta standard.
Yes.
With a pupil diameter of 4.2 mm and with a correction of plus 5.25 D sphere.
Okay.
Then showing multiple non-specific.
Before you go to the actual thing, also look at the foveal threshold. See, here it is 37 decibel, and that correlates with the visual acuity of 1.0 or 6/6. So 37 and this are correlating. So that you make a note of. Okay.
Okay. Yes,
then go ahead and tell me what you are seeing on the total and pattern deviation probability plots.
Total deviation shows a single score. A single defect is not in the noted in the periphery, and
so you here don't say single defect. Okay, these are retinal sensitivities, and when that is compared to the normative database, you are getting up 3 points here which are abnormal at P less than 2% and P less than 5%. Okay. So in the total deviation and the pattern deviation, you have 3 points just below the horizontal meridian.
Horizontal meridian, yes, ma'am.
So, and this is more on the pattern deviation rather than on the total deviation.
Total deviation.
Correct? So this,
yes, ma'am.
So do you know what this means? I mean, why is it more on the pattern deviation than on the total deviation? Do you have any idea why that has happened?
So macular pathology? No.
No. It is not affecting the macula, but you can see that the severity is put as more
Yes.
here in the PD plot
Yes,
than on
ma'am.
the TD plot. Okay. So
Yes, ma'am.
I'll explain to you. See, sometimes what happens is, though in these catch trials, you get false positive 0%. If
Yes,
a
ma'am.
particular patient has a slightly higher false positive rate, okay, then
Yes,
you
ma'am.
can have the pattern deviation plot showing more abnormality than the total deviation plot.
Oh,
Okay.
yes, ma'am.
So here you can see, if you look at the actual thresholds, you have thresholds of 30 plus in the peripheral field also. See here, you have in the periphery 30 here, upper temporal field.
Yes,
Okay.
ma'am.
Normally, you don't have thresholds of 30. So that means that though the catch trials, the patient has had no false positive, there is a slight false positive tendency. Not that it is unreliable, but when it is showing more points in the PD plot, it shows that. Okay.
Yes.
Other than that, you have told very correctly. And you mentioned the VFI and the GHT now.
Yes, ma'am. Okay. Thank you, ma'am.
Thank you.
Thank
So
you,
now
ma'am.
in this field, what do we take home? See, there is 3 points which are there just below the horizontal meridian. So keep that in mind. And when we look at the disc, we look at superior defects which could correlate with this. Okay?
Yes, ma'am.
Okay.
Okay,
Next.
thank you.
Thank you, ma'am.
Thank you, ma'am.
Left eye.
Should I ask another PG, ma'am?
Yes, please. Yes, Dr. Meena.
Okay, Dr. Nice.
I'll see if my PG is there. Abhigna, are you there?
Hello, ma'am. Yes, ma'am.
Ah.
Yes, ma'am, I'm there.
Abhigna, will you interpret this field?
Yes, ma'am, I will interpret
go ahead,
this.
Abhigna. Go ahead. You interpret
yes,
the
ma'am.
24-2. Maybe one other
Okay, ma'am.
can do the 10-2. Okay?
Okay, ma'am. So this is a visual field of left eye.
Yeah.
Showing the central 24-2 threshold or
Yeah.
CETA standard strategy with stimulus size 3 and with reliable indices and foveal threshold of 35 decibels and with full correction on near ad.
Yeah.
So the retinal sensitivity and the grayscale shows superior and inferior, superior arcuate scotoma and inferior almost hemifield defect involving the center of fovea, center of fixation.
Close to the center. See, involving the center
close to
means,
the close to center of fixation.
Yeah, point.
And and the total deviation plots show decreased retinal sensitivity in superior arcuate field and almost inferior hemifield defects of probability less than 0.5%. Involving close to center of fixation, and the mean deviation threshold exceeding the total deviation plot with the glaucoma hemifield test outside normal limits. So this visual field index of 24%, which warrants the need for doing a central 10-2
yeah.
threshold.
So any defect where the defect is close to this center, where you have a point which is, very much depressed close to this center, you need to do a 10-2. So here the pattern deviation plot is not shown because the MD threshold is exceeded. So when the defect is very severe like this, the machine will not show you the pattern deviation probability plot because it's almost generalized. Only the remaining field is small and it is localized. The defect is more than the remaining field. So in this, the PD plot is not shown. Okay. So that's good. So we should do a 10-2. So can someone else interpret the 10-2 for me, please?
Nice.
Dr. Nice.
Dr. Anuja.
Ma'am, this is single field analysis of left eye. In good reliability indices, fixation losses is there. Similar size of plus 3 and theta strategy and pupil diameter was adequate, and there is reduced retinal sensitivity in the macular area.
You didn't tell which field.
This is 10-2.
Yeah, so central 10°, 10-2 field. Okay. Okay. So what does it tell you? What does the grayscale tell you?
Grayscale is showing reduced sensitivity in the macular.
No, in the central field. Use the term central field over here. Okay.
Okay.
Okay. And then which area? So this is the left eye. So this is which, nasal or temporal? The defect.
Defect is in the.
It is in the nasal field. Okay. Superior, nasal and inferior. But there is a good field in the center which is preserved, and the defect is not very close to fixation. It is a little away. So fixation is relatively well preserved. Correct? So, and it is the same on both the TD and the PD plots, which tells you that there is no generalized component. This defect is purely localized. Okay?
Okay.
Okay. So now what is the implication of this finding? So you find that there is very significant field loss. The center is preserved. Correct? So how does it help you in your management of the patient?
In case of central vision, if the central vision is preserved, then there will be good prognosis after.
Correct, correct. So the prognosis is little better than if the defect had been very close to the center. Correct, ma. Please go ahead, Dr. Josmin.
Oh, nice.
Josmin report?
Yes, sir. With the good quality index in right eye, showing a borderline attenuation of the average RNF thickness with the infratemporal thinning. In left eye, there is severe attenuation of the average RNF thickness with the prominent inferior, superior, and nasal RNF attenuation.
Yeah. So, Dr. Josmin, now right eye let us focus on. Okay.
Yes,
so clinically, we said there were a few slit-like RNFL defects. Okay. And here, this OCT, will it help you to, rule that out, or do you still keep that in mind and say it is suspicious? Okay, I will tell you. See, slit-like defects, no? When you do a T-SNIT graph like this, it can get averaged out. Because the surrounding RNFL is normal, the slit-like RNFL defects may not be picked up on this quadrant map and this sector map, okay? The inferior temporal only is showing as borderline, and the temporal is showing outside normal limits. Temporal, we are not very much, it is not very specific to glaucoma. So we are more bothered with the superior and the inferior. So it is showing inferior borderline, but the superior normal over here, the slit-like defects may still be there. We are not very sure because it might have just gotten averaged out by the T-SNIT graph here, the sector and the quadrant. So coming to the left eye, definitely what we saw clinically, complete RNFL loss, and only the papillomacular bundle or the temporal RNFL is preserved over here. Go ahead, ma. Okay. So do you feel that the field effects in the right eye are correlating with this OCT in the right eye?
No.
We
expected, no, ma'am. We actually expect some superior thinning.
Correct. So now you have a very severe glaucoma on the left eye, advanced glaucoma, and pressure of 32 with 2 medications.
Yes, ma'am.
So how will you manage this patient, Dr. Josmin? How will you go about managing? What is your target pressure that you will set for the left eye?
We have to step up the anti-glaucoma medications and reduce the IOP by at least 50%.
Okay. Do you talk in terms of percentages or do you talk in terms of absolute number of IOP? Like, because you have a very advanced glaucoma, okay? So many times these patients with pseudo exfoliation come with very high pressures, like this patient, 38, 40, 32. So if you have a 40 IOP, for this advanced glaucoma, a 50% reduction may not be enough. 20 may not be enough, okay? So when you have a severe, very advanced glaucoma like this, we don't talk in terms of percentages. We talk in terms of lesser than 14 millimeters of mercury. So that is what the advanced glaucoma intervention study and various studies have told us. So in very advanced glaucomas, you aim for the low teens, okay? So now this patient is on which medications currently? Okay, so what will you add and what do you expect from that?
We can add a prostaglandin analog to
Excellent.
the left side.
Yeah. I say it doesn't come down or it comes down to 22, 21. What will you do next? Yeah, you have to go to surgery only, correct? Why you are hesitating? Okay, so tell confidently. So there's nothing wrong. You will try, you will discuss the treatment options with the patient. So, okay, patient, if he's affordable and willing to put more medications, you can give. But you will monitor closely and you will advise surgery if medicines are not controlling the IOP, okay? So when you have pseudo exfoliation and glaucoma, like in this patient, do you think you should be more careful about these patients? And if so, why?
They have an aggressive clinical course when compared to normal primary open-angle glaucomas.
Yeah.
And
Correct.
they rapidly deteriorate.
Correct.
The glaucomatous changes.
Yeah. So they progress very rapidly.
So they have to be under regular follow-up.
Correct.
The other eye also has to be monitored.
Even
if there are no clinically evident pseudo exfoliation.
Yeah. So, Dr. Meena, you may want to ask something. I think I am only speaking.
So the problem with this patient is actually he's from the CRPF. He's come on a short vacation. He's not going to be with you. He's not willing to accept surgery because he's just come on the brink of his leave. And we know he's going to be a non-compliant patient because if he was identified to be a glaucoma suspect about 2 years back and he's, stopped the medicine by himself, then I don't think how much ever you counsel him, he's going to be turning into a compliant patient. So I think that we should enforce the need for a surgery in him so that he really thinks seriously about it as far as the left eye is concerned. And
absolutely.
Yeah. And regarding the right eye, Josmin, do you think you would want to do a better baseline? Because when you get a field which is not correlating, like Madam said, with the disc picture, and she gave you explanation why the superior slit NFL defects could not come out with a positive thing in the OCT. So do you think in this scenario, a repeat baseline of the right eye would be helpful to you? And would you ask the patient to do one?
Yes, sir. Repeat baseline test will be.
Yeah, I think it should be done. So what are the chances of getting pseudo exfoliation in the other eye when you get such asymmetric pseudo exfoliation glaucomas? What is the reported?
More than 20% patients.
More than 20% risk of getting a pseudo exfoliation in the other eye? Yeah.
So the pseudo exfoliation, say you do a cataract surgery for this patient, So does the process stop after cataract surgery, Dr. Josmin?
No, no.
So it continues even after cataract surgery. Sometimes you have these deposits on the IOL also. And it is a systemic disorder and not just a ocular disorder. Okay.
After the cataract surgery, there will be a reduction in the IOP. So you
Hmm.
should not get carried away saying that the intraocular pressure has come down. You have to emphasize on each visit that they're dangerous culprits to convert into the ordinary POAG rather. Even though the nidus for the exfoliative material is gone, there is a high risk. Could there be any other risks in such patients? Can they be steroid responders?
Any patient with glaucoma is more likely to be a steroid responder, Dr. Josmin. So you will not be wrong when you say, yes, they are likely to be steroid responders. Okay. So glaucoma patients, first degree relatives of those who have glaucoma, they are more likely to be steroid responders. Okay. So that is something that you'll have to keep in mind. So here there is no phacodonosis. It's just a pseudo-exfoliative glaucoma, no cataract also. So relatively straightforward, we focus on the management of the glaucoma. So medical, and if that is not possible, then surgical. And as Dr. Meena said, in this patient, since compliance and follow-up are an issue, probably surgical would be the best option for this patient. Once he has defaulted and there is a risk that he will default once more.
Yeah.
Okay.
And like Madam picked out that there's a possible disc hemorrhage, I think we should scrutinize on this. And if there is a disc hemorrhage, vasospasm and a normal pressure causing a disc hemorrhage chance is very high. So doing a diurnal check on this patient on treatment probably would, because you are thinking of adding a prostaglandin analog only for the left eye, isn't it? Because the right eye is having a normal corneal thickness, and as an IOP you mentioned in the range of how much? 16 or 14?
16.
Yeah, 16. So since you are only thinking of in terms of a suspicious superior notch, you probably would think that 16 is ideal. But this patient should not get a disc hemorrhage if it is a disc hemorrhage. So once you confirm that if you think it's a resolving disc hemorrhage, it's worthwhile doing a DVT, I feel, on at least the diurnal during 3 or 4 readings over a daytime, to know whether the fluctuation is wide or not.
And if it is a confirmed disc hemorrhage, one would start treatment to the right eye. Because even though your IOP is just a snapshot, you don't know. During the night, it may be fluctuating. Other days, it may be fluctuating. The fact that there are slit-like defects is one warning sign for you. And if there is a splinter hemorrhage in addition, it is like a clincher. This eye is also having that tendency. Okay. So just because this eye doesn't have pseudo-exfoliation doesn't mean that this eye will not develop glaucoma. Okay. So, and pseudo-exfoliation may also develop later on, like Madam just also pointed out to you. So if it is confirmed, the suspicion, you would rather treat the right eye as well. Okay.
Okay, another question, just deviating from the topic. If you had not seen the pseudo-exfoliation and you had got an asymmetric IOP like this, and you find a glaucomatous damage also so asymmetric, then what other causes you could think of in the DDs?
Pigmentary glaucoma.
Okay, pigmentary. Then again, pigmentary, you would expect some Krukenberg spindle, or at least the gonioscopy would be a hallmark with the hyperpigmentation of the trabecular meshworks. Very many times you look at the angles and then go back to see the spindle and then go back to reassess. So pigmentary is an option, of course, that you already mentioned in your DD. Pigmentary and a unilateral POAG. Apart from that, I just wanted you to think of some of the secondary causes. That is why I asked this question. Anything you can think of? Anything anybody else amongst all these PGs can think of, they're welcome to unmute.
I think you have to tell the name, Dr. Meena, otherwise they won't unmute.
Dr. Sarika, can you think of anything? I think they're not hearing us or what?
I think it is better to tell them to switch on the videos. So that we confirm their presence.
So that's okay. Jasmine, any other secondary glaucoma? Like you can have occult neovascular glaucoma where there is a new blood vessel and you have not picked it up on cursory examination, uveitic glaucomas. So asymmetric pressures, it points out to a secondary cause sometimes. Of course, primary glaucoma, pseudoexfoliation can be asymmetric. But when it is grossly asymmetric, you should also keep in mind that there may be secondary causes. Okay.
And though you mentioned that no history of drugs, no history of steroids, if you again double cross check and question, sometimes you will get an occult trauma, occult past unilateral blunt trauma to the eye, etc. In wide open angles, you may have missed the angle recession, which is there subtle.
True.
And so you don't believe them on their face, when they say there's no blunt trauma, there is no past history of steroid use, etc. So these two things also you can, apart from what Madam has pointed out, in your ocular ischemia on one side, so asymmetric actually, but you will get some new vascularization if you get such a high IOP in a ocular ischemia.
You can see the area of that peripapillary atrophy very nicely on your OCT, if you can see it. Can you make out? Both in the right and in the left eye. And the right eye also has peripapillary atrophy. So definitely this disc is quite suspicious only. So you will keep a very close watch.
Actually, the right OCT is highlighting the inferior peripapillary atrophy. And the chances are, like Madam said, I feel that the superior normal is not probably normal. It is a false normal depiction. The inferior is as accurate as this being picked up probably. So probably this patient has a little bipolar thinning is there.
It's good, very nicely documented everything, Dr. Josmin, and very nicely taken history and presented. Very, 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 correct.
Actually, she had taken gonio CPs also, poor girl.
Okay.
And our ACP machine at the last minute, it has lost all the data. It's gone for.
Okay.
That's why she was a little worried what to do if you will ask her.
No. You mentioned, you put the diagram and you said now that it was open. So we'll take it at that. Okay. So pseudoexfoliation is associated with only open angle glaucoma or other forms of glaucoma as well? Dr. Josmin.
There is subluxation of lens, it can cause angle closure.
Yeah, it can be with.
What did you say?
Subluxation of lens.
Yeah, per se, subluxation can cause narrowing of the angle, but it can be associated with angle closure as well. Sometimes you have pseudoexfoliation and you have narrow angles on gonioscopy. So
very many times you may have to, like, they come with occludable angles sometimes.
Okay, so both types can be there, open angle and angle closure.
Dr. Josmin, you can come out from you can just close the screen. Stop sharing the screen. Yeah.
Okay.
Yeah.
Anyone wants to mention about the genetics behind pseudoexfoliation from academic point of view? We see so many names, but then
I think you can switch on the video.
Sonia, you have anything to say about the genetics behind?
Yes, ma'am.
Yeah, tell.
Mostly it is a production of an abnormal fibrillary protein, mostly sporadic in nature, related to LOX1 gene mutation.
Good.
Yeah. So there are many genetic predisposition is definitely there. So lysyl oxidase-like enzyme, that is what, not the LOX, that is the one which is implicated, and a gene on chromosome 8 that is also implicated. Okay, so There are many, genes which are there, which are implicated, and definitely it has a genetic predisposition. What are the other risk factors for pseudoexfoliation apart from genetic predisposition? Where is it more common? Abhigna? Since I know only you, I'm going to ask you only.
Yes, ma'am.
What other risk factors are there? Whom do you see pseudoexfoliation more commonly in? Risk
Age
factor.
can be one of
Yeah,
them.
definitely. Age is the risk factor. Then?
And
they say high altitude. Okay.
Yes.
So because it is very common in the Nordic and Mediterranean population. And they say the high altitude or solar or solar radiation, like those things can also cause more pseudoexfoliation.
Yes.
Okay. And then female sex, little more preponderance compared to male sex.
Males.
And as I told you, smoking, caffeine, alcohol, anything that causes oxidative stress, those are risk
Yes.
factors for pseudoexfoliation. Okay.
Okay.
What percentage of pseudoexfoliation patients go on to develop glaucoma? Anybody?
50%.
Many of them. If you take overall open angle glaucoma patients, 25% of them will have pseudoexfoliation. 15% is correct.
Incidentally, I was just seeing now that sometimes a pseudoexfoliation patient can present with CRVO. So vascular occlusions can be a presenting feature that could be related to the high IOP because they can go to very big levels.
Correct.
The single disc hemorrhage is a very, very important finding, which madam has picked out actually.
It may be an artifact from the fundus photo also, Dr.
Also,
Meena.
because I didn't see it actually. It's not reported in my EMR. So.
So very good. Do you have any questions, any of you, which you want to ask? Dr. Josmin, you can ask anything that you want.
See, the idea of putting more of you in the Zoom is to have lively discussion. So you can ask questions and you can actively participate in the discussions also.
True, true. This is not an exam, na, Dr. Joseph?
Yeah, yes.
Yes. Why
Actually, Baston, I think next time you make it compulsory that everybody puts into the video mode, you know?
Yes.
It is good for us. We can see a lot of faces also.
Yeah, correct. So unless you ask questions, like you cannot correct your wrong concepts. So even if it is wrong, you keep on asking questions and tell wrong answers also.
Though in our practice, we are not using laser SLT for such patients. Is there a role for SLT in pseudoexfoliation glaucoma? Just wanted to know what your concept is.
SLT definitely, ma'am. For any open angle glaucoma, that figures in the treatment algorithm. And it could work even in pseudoexfoliative glaucoma. But then I think overall, the experience of SLT in the Indian population has not been very encouraging. And second, the selective laser trabeculoplasty machine is not there in every hospital. So there is a limit to it's a standalone machine and you have to have access to it. So the alternate would be diode or argon laser photocoagulation. So that does damage the meshwork a little more than the selective laser trabeculoplasty. So I would say the response in Indian eyes has not been very encouraging amongst the people who have been doing it, SLT. And second, not all of us have access to it. So that makes it a little, that doesn't figure in our treatment algorithm.
Yes.
So otherwise, that is also, like you said, this patient, he is going, CRPF person,
Yeah.
he is going away and he may not have time to get surgery done. So in such situations, doing a selective laser trabeculoplasty will give you that little bit extra in addition to the medications that you're using. So one can't rule it out. I mean, it does have a role to play.
Yeah. And with all the pseudo-exfoliative material in the trabecular meshwork, the dysfunction element is quite a bit. So like we said, even though the failure rate is going to be high, this may give you some extra leverage till he comes back to you for surgery along with the medication.
True.
So in fact, Dr. Rosman, that was a wonderful presentation. And so shall we conclude, Dr. Gauri?
Yes,
Anything
sir.
to
Yes,
discuss?
definitely. Thanks so much. It was a very nice presentation.
Yeah.
And a very nice initiative
us
on
also,
the part of your society also.
Yes.
Thank you, ma'am.
Thank you very much for spending spending your valuable time with us.
No, thanks for having me.
Dr. Meena,
thank
you very much.
Yeah.
And all other PGs who are switched off with their videos. Okay, thank you once again.
Thank you.
And have a good night.
Thank you. Thank
Good
you
night.
all of you. Thank you.
Marian, you are in the theater?
You're operating at this time. Working very hard.
You're muted.
You're preparing for AOS.
Okay.
With the OT dress?
No. I just came out of OT. Like, so many things are happening in the background. Yeah.
Okay.
Thank you all.
Thank you.
Yeah, thank you.
Okay, good night. Bye.
Good night.